Imagine, uh, you're a firefighter. You arrive at a house fire, you grab the nearest bucket of clear liquid, and you just throw it straight onto the flames.
Thinking it's water, obviously.
Exactly, thinking it's water. But it wasn't water, it was, a bucket of gasoline.
Oh, wow. Yeah.
Right, so the fire doesn't just keep burning, it explodes. It becomes like 10 times more dangerous than when you arrived. And sometimes when we try to treat adolescent mental health without the exact right map of what is biologically going on, the quote-unquote obvious solution actually makes things exponentially worse.
It's a stark image, but honestly, it is the perfect way to frame the terrain we're navigating today. Because the focus of this deep dive isn't just about the broad, feel-good idea of getting teenagers access to mental health care.
Right, which everyone agrees on anyway.
Exactly. It's about the absolute non-negotiable necessity of establishing the correct diagnostic baseline before taking any medical action whatsoever. Because without that baseline, you are essentially, you're fighting a fire blindfolded.
Totally. And to ground this conversation for you, the listener, we are looking specifically at the framework and the real-world data generated by MentalSpace School.
Which is fascinating, by the way.
It really is. They are a comprehensive K-12 mental health support system, and they're operating inside schools in Georgia. So they are dealing with this day in and day out. And their approach gives us a really clear lens into how we are currently treating, and far too often, completely mistreating our teens.
Right. And to understand why getting that diagnostic baseline is so critical, we first have to look at the timeline. We need to look at when these specific mental health risks actually surface in a young person's life, and crucially, where those risks originate from in the first place.
So before we get to the gas lane, let's talk about the house fire itself. Like, when do these fires actually start? If we look at bipolar disorder specifically, the onset typically hits right between the ages of 15 and 19.
Right, late teens.
But the tricky part is that the underlying symptoms often begin percolating even earlier than that. We're talking like middle school, early high school.
Which is an incredibly volatile window to begin with. The biological onset is colliding directly with the social and hormonal chaos of simply being a teenager.
Wait, I need to stop you there because I think this is where a lot of people get confused. Isn't every single teenager turbulent between the ages of 13 and 19?
Yes, pretty much.
Right. They're dealing with immense social pressure, their brains are actively pruning synapses, their hormones are just everywhere. How on earth do you spot a genuine clinical mood disorder in a 14-year-old versus a kid who is just, having a really rough semester?
That is precisely the problem. And it's why so many cases just slip right through the cracks. It's incredibly difficult to distinguish between typical adolescent angst and the early rumblings of a mood disorder without a structured screening process.
Because they look so similar from the outside.
Exactly. And the stakes during this specific window, they could not be higher. Untreated bipolar disorder carries the highest suicide risk of any mood disorder.
Oh, wow.
Yeah, we really have to pause and sit with that fact. It means that early detection isn't just about, improving a teenager's focus in math class or making family dinners a bit more peaceful. Early detection literally saves lives. It is the dividing line between a tragedy and a thriving young adult.
Okay, let's unpack this, because there's a massive predictive factor here that I think trips a lot of people up, and that is family history.
Huge factor.
Right. If a parent has bipolar disorder, the data strongly suggests you need to screen the child. But there is this enormous, unspoken societal stigma around screening kids for mental health issues. And I have to push back on that because the logic just completely falls apart if you apply it to any other area of medicine.
It really does. It's completely inconsistent.
Think about it. If a parent wears glasses, what do?
They get their kids' eyes checked.
They immediately check their kid's vision before they even start kindergarten. They don't wait for the kid to start failing reading comprehension because they can't see the whiteboard. They screen for it. So why do parents hesitate so much to screen for a mood disorder if it is sitting right there in their own family history? Is it just like sheer fear of the label?
Often, yes.
But the consensus from the experts on the ground is that this kind of screening is smart prevention. It's not paranoia.
If we connect this to the bigger picture, we can understand that hesitation even as we try to dismantle it. Parents are terrified, they hear bipolar, and they immediately picture a lifelong limiting label for their child.
Right, they panic.
But what's fascinating here is that knowledge of a family tree, knowing the mental health history of parents, of aunts, of grandparents, is actually the ultimate diagnostic tool. It is the flashlight in the dark room. By identifying the genetic risk early, you change a terrifying, chaotic unknown into a highly manageable medical condition.
So you're saying the diagnosis isn't a prison sentence. It's actually the blueprint for getting out of the prison.
Precisely. With proper treatment, which typically involves a regimen of mood stabilizers combined with consistent therapy, teens with bipolar disorder absolutely can and do thrive.
That's amazing.
They go to college, they build careers, they live full, successful lives. The tragedy isn't the diagnosis itself. The tragedy is missing the diagnosis entirely.
And missing the diagnosis leads us straight to that bucket of gasoline I mentioned earlier. If early detection makes this so manageable, what happens when a teenager actually asks for help but gets the wrong kind of detection?
This brings us to what is arguably the most dangerous, counterintuitive medical trap in adolescent psychiatry today. It is a systemic pitfall that catches so many well-meaning families and clinicians completely off guard.
Here's where it gets really interesting and, frankly, incredibly alarming. We are talking about standard depression treatments, specifically SSRIs.
Right, very common antidepressants.
Yeah, prescribed all over the world. But when an SSRI is used alone, without a mood stabilizer in the mix, it can actually worsen undiagnosed bipolar disorder. The sources call it treatment-induced mania in undiagnosed bipolar II adolescents, and it's a heavily documented adverse event.
Very heavily documented.
But I have to ask you, as someone trying to understand the clinical reality of this, how does a trained doctor confuse these two things? Aren't they explicitly looking for the manic highs of bipolar disorder? It just seems like a massive oversight to hand over a prescription for an SSRI if there's any doubt.
What's fascinating here is the mechanics of how this misdiagnosis actually happens in the real world. To answer your question, it is frighteningly easy for a trained professional to miss it because of the way patients actually present in the clinic. Bipolar disorder is characterized by extreme mood swings.
The pendulum swing.
Yes, the highs, which we call mania or hypomania, and the lows, which is the severe depressive phase. But here's a catch count. Teenagers rarely, if ever, show up in a doctor's office complaining about feeling too energetic, or too confident, or needing too little sleep. During a hypomanic phase, they often just feel highly productive or intensely social. They don't think there's a problem at all.
That makes total sense. They're just like, hey, I'm having a great week.
Exactly. They show up to the clinic or, their parents drag them in during the depressive phase. They are lethargic, deeply sad, totally withdrawn from their friends.
So the doctor is only getting a snapshot in time. They're only seeing the valley, not the peaks.
Exactly. If a clinician only sees that depressive snapshot and they don't explicitly pause to run a specialized screener for a history of mania or ask about that crucial family history we just discussed, they will logically diagnose standard unipolar depression.
Because in that specific 20-minute appointment, it looks exactly like standard depression.
That's right. And so, acting with the absolute best of intentions, the doctor writes a prescription for an SSRI to help lift the depression. But here is the biological danger of treating only half the equation. Think of an SSRI like a powerful engine in a car. In a standard unipolar depressed brain, the car is stuck in the mud, and that SSRI engine helps pull it out. But a bipolar brain isn't just stuck, it has an entirely different structural issue. It's a car missing its brakes.
Oh, man.
If you drop a massive high-powered engine into a car with no brakes, it doesn't just drive normally, it rockets out of control.
Oh, wow. So the antidepressant acts as the massive engine, but there's nothing chemically slowing the brain down.
Precisely. That's what an SSRI does without a mood stabilizer acting as the brakes. Lifting that mood without a chemical ceiling forces the brain into a severe overdrive state. It acts as a catalyst, catapulting the adolescent straight out of the depression and rocketing them into a severe manic episode.
That sounds intense.
It is. The teenager's anxiety spikes, their impulsivity goes through the roof, their need for sleep completely disappears. I mean, they might stay awake for 3 days straight.
Which must be utterly terrifying for the parents. I mean, they finally got their kid help, they gave them the medication the doctor ordered, and suddenly the child's behavior is more erratic and dangerous than ever before.
It is a total nightmare scenario for a family. The parents think the depression has mutated or the teenager is just getting fundamentally worse, when in reality it is a treatment-induced crisis. This isn't a failure of the teenager to respond to help. It is a fundamental failure of the screening process before that prescription pad was ever pulled out.
It is literally throwing gasoline on the fire, and the consequences are just devastating. which is why the consensus on the ground is absolutely adamant about prescribing considerations. Before initiating any SSRI therapy for recurrent depression in an adolescent, a brief bipolar screen must be the absolute standard of care.
No exceptions.
Right, no exceptions. Before you write the script, you run the screen.
It has to be a non-negotiable step. If you are going to chemically alter the neurobiology of a developing 15-year-old brain, you have a medical obligation to map the entire landscape first, not just the valley of depression they happen to be sitting in on a Tuesday afternoon.
So, if the stakes are this high, and this terrifying medication pitfall is this easy to fall into, how do we actually fix this on a broad systemic scale? Because relying on every exhausted pediatrician or family doctor to catch this in a 15-minute window clearly isn't foolproof.
No, it's not.
How do we ensure families aren't just navigating this absolute minefield completely in the dark? This is where the model built by MentalSpace School comes in, because they have seemingly engineered a safety net specifically designed to solve this exact problem.
Yes, what they have done is take the clinical necessity of screening and integrated it directly into the daily ecosystem of the student. It's an incredibly practical model of healthcare delivery that bypasses a lot of traditional hurdles.
Let's look at how they actually execute this.
Yeah.
First, they tackle the screening issue head-on. They use a completely free, family-friendly screener. It's an MDQ-style test, which stands for Mood Disorder Questionnaire.
Yeah.
And the brilliance of it is just the simplicity. It takes only 2 to 3 minutes to complete. You can find it right on their site at techhetherapy.com/mentalhealthtests. 2 to 3 minutes. That is less time than it takes to scroll through a social media feed, and it could prevent that catastrophic SSRI trap we just spent 10 minutes talking about.
And importantly, they don't just leave families with a test score and say, well, it looks like there's a risk of bipolar disorder. Good luck finding a specialist.
Right. See ya.
Exactly. That is where so many public health initiatives fall short. They identify a problem, they raise awareness, but they provide absolutely no bridge to the actual solution.
Right. MentalSpace builds the bridge. They coordinate directly with pediatric psychiatrists across Georgia for full integrated bipolar care. But I want to understand how this functions day to day. You don't just, drop a psychiatrist into a high school cafeteria.
Right.
How do they actually deliver these services?
The mechanism is what makes it work so well. They offer same-day teletherapy, and they assign dedicated therapist teams to specific schools. They also handle crisis intervention, suicide prevention, and family counseling. And all of this is done by licensed, diverse, culturally competent therapists.
When I was looking into their infrastructure, the analogy that jumped to mind was maritime rescue.
Oh, I like that.
Yeah, it's not just tossing a life preserver to a drowning kid and hoping they can swim to shore. It's parking a fully staffed hospital ship right inside the school's harbor.
Yeah.
But practically speaking, how does a student access that ship without it being a massive disruption to their education?
It works through the systematic removal of friction. If we connect this to the bigger picture of traditional mental health care, the friction for a family is immense.
Oh, for sure.
Let's say a parent notices a problem. First, they have to find a specialist who is actually taking new patients.
Good luck with that.
Right. Then they wait 3 to 6 months for an intake appointment. When the day finally comes, a parent has to leave work early, pull the kid out of school, drive across town, sit in a waiting room, and then drive all the way back. By the end of it, a simple therapy session has consumed half a workday and caused massive social friction for the kid, who had to explain to their friends why they were leaving school early.
And that's assuming they even have a car or a job that lets them leave in the middle of the afternoon.
Exactly. But by placing teletherapy infrastructure directly in the school ecosystem, that friction vanishes. A student can get a pass, walk down the hall to a designated private wellness room, log on to a secure session with a culturally competent therapist, and then walk back to math class 20 minutes later. MentalSpace completely removes the geographical and temporal friction.
Looking at it objectively, that makes total sense. But we also have to talk about the financial friction, because for a lot of families, that's the ultimate brick wall.
It's the biggest barrier, absolutely.
So MentalSpace is fully HIPAA and FERPA compliant, and they accept a massive range of major insurances: BCBS, Cigna, Aetna, UHC, Humana, Peach State, CareSource, Amerigroup. But the linchpin of their whole model is how they handle Medicaid. For students on Medicaid, the cost is $0. Zero.
Which is the ultimate game changer. It democratizes access to that crucial diagnostic baseline we've been talking about. When the out-of-pocket cost is $0 and the therapist is virtually down the hall from the student's classroom, early detection goes from being a luxury of the privileged to a standard reality for the entire community.
And if we look objectively at their outcomes, the numbers really track with that removal of friction. They're reporting an 89% improved attendance rate among students in the program, a 92% reduction in anxiety, and an 85% family satisfaction rate.
Those are incredible numbers.
They really are. Makes logical sense. If you remove the hurdles to getting the right diagnosis, and you treat the underlying issue rather than accidentally making it worse, compliance naturally goes up. You give kids their lives back, and you give schools their students back.
Because when you treat the correct condition with the correct tools, the fog lifts. The student isn't fighting a biological fire with a bucket of gasoline anymore. They finally have the right map, and with that map, they can navigate their own potential.
So what does this all mean? If you were listening to this right now, whether you're a parent trying to read the tea leaves of your teenager's mood swings, or an educator watching kids struggle in your classroom, or just someone curious about how our healthcare systems actually function, understanding these specific biological mechanisms empowers you.
It really does.
We've explored how a mood disorder isn't just acting out. It's a deeply biological condition with a stark family history component, typically showing its face between the ages of 15 and 19. We've uncovered the frightening reality that standard treatments like SSRIs can act like an engine without brakes, triggering severe mania if an underlying bipolar condition goes undetected.
The SSRI trap.
Right. And most importantly, we've broken down how systemic, frictionless solutions like MentalSpace School's integrated model can completely alter the trajectory. A simple, free 3-minute test, combined with accessible care, changes the entire narrative from a state of crisis to a state of thriving.
It absolutely does. And as we wrap up today's deep dive, there is one final piece of this puzzle that I want to leave you with to mull over.
Okay, let's hear it.
We've talked extensively today about the absolute necessity of having the right map and how an undetected mood disorder can turn a standard medical intervention into an emergency. So this raises an important question. If a simple 2 to 3 minute screener can prevent a catastrophic medication error and quite literally save a teenager's life, why isn't a comprehensive family mental health history treated with the exact same routine, unquestioned urgency as asking about a family history of heart disease or allergies during every single standard physical?
Oh.
Think about that the next time you or someone you love is sitting in a doctor's office. Until we demand that the mental map is treated with the exact same respect and thoroughness as the physical one, we are still just guessing at which bucket to throw on the fire.